Okay, so our group will expand by 4 more people, 4 more students over the coming weeks. And so I'll be happy to repeat this for them, or you're recording it so they can watch it, right? So what I want to do is, of course, welcome you and discuss with you our expectations, hear from you what your expectations are. It's important that we know what your expectations are so that we can help you accomplish those. Our expectations are that you're going to learn about addiction and about doing addiction research, and that you're going to enjoy it. You will enjoy it. And we hope, as with last year, that we'll be able to come up with at least one publication. It won't happen this summer, I assure you. The one from last year was published, I think, about a month ago. So it takes a really long time to go through the whole review process. But it would be nice if we could at least get really good drafts, and we can always finish those remotely and submit them and go through the whole review process. Publications are sort of the lifeblood of research efforts. And if you don't document them in publications, it's as though they never happened. So we put a high priority on publishing the work we do. Now, that said, we're not going to just try and publish anything. So we're going to have to, focus on thoughtful projects and work hard at it. Questions that you have? Any questions? There are no questions that are not acceptable. I want to talk about the debt ceiling. I mean, anything meaningful. I'm well steeped in this. Okay. Hours. So we are not really rigid. And if there's something you need to do, just let us know that you won't be here. But generally, we'd like you to be here Monday through Thursday, regular hours, like 9 to 5, 8:30 to 5, something along those lines. Some of you, I think, are getting paid by the hour. Maybe all of them? No. Okay, so and so you'll need to provide your hours to whoever, either to Tim or to Sabrina. If you're NIDA students, Sabrina. If you're not, it's Tim, unless you're with ITMAT. It's very complicated. We have like 5 or 6 different sources for support for students because there are 9 students. And I think that's great. I think it's fine. We'll just work with what we have in terms of the requirements of each of those programs. Fridays we'll make flexible. You can come in or not. If there's a reason you want to work remotely a different day, just let us know. We'll discuss it in advance. But communication is real important. Tell us what's going on. Tell us if you have concerns. Definitely can't do anything about concerns that we don't know about.
One thing I'd like to add to that, actually, which I forgot to mention to you, but if anyone is feeling unwell, don't come in. Do let us know. But
take care of yourself at home.
Well, take care of yourself at home, but also even if you've just got a bit of a sniffly nose and so on, we're obviously coming off of COVID, we hope, and we'd like to all stay healthy over the summer. So, if you're feeling well enough to work but still a little off, stay home, work remotely, and that's absolutely fine. Is that okay?
Sure.
I just don't want to get sick.
So just to be clear, Rachel, Emily, and Sabrina are in essence running the summer program. So if you have any problems, just go to them. No, I'm just kidding.
Yes, any praise go to Hank.
And what's that?
Any praise go to you.
That's right. That's right. I think we're all here much of the time. Some days I work remotely. Some days each of us works remotely. We should probably make you aware of those days in advance, and maybe we can make an effort to do that. Put something in Box. Box is a great way for us all to share information. And
should
there's,
have all been added. If you haven't gotten an invitation from me, let me know. We can use a different email.
yeah, it can be a little finicky in terms of the email. But there's lots of stuff in Box. You should rummage through it. There's a syllabus, there's the lecture series, there's a bunch of articles, there are grants that are the basis for the studies that we're doing. So I think all of that's there now. So there's a lot of information. So if you don't know what to do with yourself, go to the Box folder, pull out an article, print it, or if you like reading online, read it online. But there's lots for you to become familiar with. Questions? Comments?
Do all of you have access to the building?
Yeah.
My card doesn't work. My, like the psychiatry card works, but my pen card doesn't work to open the door here on this floor.
All right, so we can,
Get permission.
when we get permission
Yeah.
to do.
It can take a while. Yeah.
I have your card.
We do plan some social activities for the whole group. Starting with a lunch after everyone's here, which I think will be on the 13th at noon. And that's 2 weeks from yesterday.
Sure.
Right? 2 weeks from yesterday? Yeah, okay. All right.
2 weeks from 2 days ago.
And I have one more. How many people like baseball? Nobody? Nobody wants to see the film? Okay, so,
You don't actually have to watch the game. The point
Yeah.
of going to a Phillies game is not actually to watch the game.
I mean, I'll go with you, but I'm from Boston, so I can't rep the Phillies.
oh.
It's there.
Wait a minute. We didn't know you were from Boston. That kind of changes.
I used to live over there, so in fact, I came here from Boston area. But you can still go and have fun. They have lots of new little restaurants out there and everything.
Aren't they playing Boston?
Yeah. I'm gonna get with you
This
later.
is not a good year for the Phillies.
I'm going to get with anyone who's interested in the date, that, you know, obviously their home dates, and then ask for tickets based upon your interest, how many people I get. So if you're interested, then send me an email or see me. Office is 560 on this floor.
So
Right.
all of our offices are on the outer wall at that end. The whole line is where Sabrina's at one end, I'm at the other end. Rachel and Emily are in between. Zeal is in between. Tim is in between. Rachel's on this corridor at the end.
And that's also when pretty much everyone will be sitting, right? The-
Right,
the
right. You'll all be
cubicles are
sitting
all
there.
Set up along that
Carol's
row
there,
as well.
yeah. Okay. All right, so what I want to cover in today's talk are some basic statistics and definitions. You're going to hear a lot about alcohol use disorder, opioid use disorder, because those are the two disorders we study the most. But there are lots of labels, and we use different databases. So we use electronic health records, which generally use ICD, International Classification of Diseases nomenclature, rather than Diagnostic and Statistical Manual of Mental Disorders, or DSM. So I'm going to show you some differences. You'll at least be conversant with the terminology, because you'll see it in all of the papers that we write, either the DSM or ICD diagnoses, sometimes both. So I'm going to talk about statistics on alcohol consumption and different drinking levels, and then diagnoses across the two systems, DSM-4 and ICD. DSM-4, DSM-5, and ICD-9, ICD-10. There's now ICD-11, but I don't think it's in.
Really?
it's in widespread use yet. Yes. Okay, so per capita alcohol consumption in selected countries. Now, these are not all, obviously, all the countries either in North America or Europe, but many of them. And you can see that the US is actually toward the bottom, just below Canada. And Lithuania is way up at the top. So people drink a lot more in Eastern Europe than they do in Western Europe, for example. So it gives you a sense of how many liters of ethanol are consumed a year. So ethanol is the chemical name for alcohol, what we colloquially call alcohol. And it is measured in liters. A typical, a standard drink contains 0.6 ounces of ethanol. So there's some conversion between ounces and liters, which I'll show you. And grams are also important in measuring ethanol consumption. And they're interconvertible, but you need to have some idea of how to interconvert them. So a standard drink, which is shown here is 0.6 ounces of ethanol, is the amount an average person, whatever that is, metabolizes in an hour. And obviously this varies by sex, it varies by weight, body weight, and it varies by body composition, which kind of overlap the other two. So women metabolize alcohol more slowly than men. More lean mass, so more muscle mass metabolizes alcohol more quickly than fat. And men, let's see here. So that's about it. But we're talking, when we refer to a standard drink, of 12 ounces of regular beer, which is generally 5%. Of course, there are craft beers that are 9%. So you have to know the percentage, but these are just kind of guidelines. 5 ounces of table wine, which is 12% alcohol. And again, very few wines now are 12%. And we can have a talk on wine at some point if you want to. And 1.5 ounces of hard liquor, rye or whiskey, is 40% alcohol or 80 proof. So alcohol percentage doubled is proof. And I'm not sure why people use proof, but 86 proof is a common common proof for, say, whiskey. So that's 43% alcohol. And you can see there are other beverages there, cordials, liqueurs, aperitifs, fortified wine, like port. Port can be 18% alcohol by volume, or ABV. And so you have to think about the interconversion. Now, I'm using alcohol because we know these. But when you're talking about heroin or fentanyl bought on the street, all bets are off. The amount of drug contained in a bundle or a $10 bag can vary widely. And that's a major contributor to overdose deaths. People think they're buying one thing, often heroin, at least they used to, not anymore in Philadelphia. Everybody knows it's all fentanyl. They got fentanyl. Fentanyl is an incredibly powerful opioid, but 500 times more powerful than morphine, and it kills people. But alcohol is based on weights and measures that are overseen by the government. So when you buy a bottle of wine, if it says it's 13% alcohol, probably is. So some definitions of binge and heavy drinking. These are for the National Survey on Drug Use and Health, which is a governmental survey that's done annually. It's a very useful source of information. It's fondly referred to as NUSDA. It has a lot of information about people's substance use. So alcohol, different drugs, smoking by age, by sex, by population group, and it's done annually. Treatment resources utilized. It's a wealth of information. It's a lot to wade through. You can actually download a really large PDF if you're interested in it, but it's a rich source of information. So binge drinking is generally considered 5 standard drinks in a day for men and 4 standard drinks in a day for women, or more. Heavy drinking is binge drinking 5 times or more in the past 30 days. No, so why do we care about binge drinking? It's binge drinking that gets most people into trouble with alcohol because they're intoxicated. This is a level at which most people are at least mildly intoxicated and probably above the legal limit to drive. And accidents happen, lampshades happen, all kinds of dumb things happen, and dangerous things happen at those levels. I'm not moralizing here. I'm just describing what happens. In the US, 6.6% of the adult population in the preceding month. I wonder why I didn't update these statistics. It hasn't changed that much. I'm not sure why I used 2010. There are 2021 now. Anyway, these numbers don't change, have not changed that much. I think because, well, the annual alcohol-associated deaths are approaching now 100,000 a year. So, you know, we get very concerned, and appropriately so, about 100,000 opioid or drug-related deaths a year. But every year, people have been dying at that rate from alcohol-related causes because alcohol is widely available. It used to be advertised all over the place. It's still advertised in lots of places, not on TV. Are there any beer ads on TV now? I don't think so. There aren't. They're beer ads,
We
but they're
watched
not.
the Super Bowl.
Oh, yeah.
Yeah.
Yeah, I was too drunk to. Just kidding. The 2010 number that has not been updated is U.S. alcohol-related costs of $249 billion. That may be why I ended up using only 2010 numbers here. But basically, 1 in 15 people in the US is a heavy alcohol user, meaning 1 out of 15 people drank 5 or more times at a binge level in the preceding month. So it gives you an idea. That's a lot of people. If there are, these are adults, so I think there are probably around 250 million adults in the US. And so 7% of that is a lot of people. And, you know, binge drinking is present in about a quarter of people. In terms of, by the way, if you have questions, just interject them. You don't have to wait till the end. You don't have to raise your hand. You just say what's on your mind. DSM-4. Yeah. Good.
Can you go back to the other slide with the binge drinking and the
This one?
yeah, because I'm wondering, like, when does like binge drinking become binge drinking? Because I know that like a lot of people like what is the difference between like someone just like going out and drinking like having like twice a month?
That's binge drinking twice a month.
Right, but like what if it's like a social setting? Like, does it matter like what? No.
All that matters is how much goes down the gullet.
So like when does it become a problem? I guess is the question.
It can become a problem the first time if you're intoxicated and you get into a fight, or you're intoxicated and you say something you wouldn't say if you were sober, or you have a motor vehicle accident. It's a problem. So the expert on when heavy drinking becomes alcohol use disorders is Dr. Kember.
Genetically, but not.
There's no simple way to define that transition. And so we talk about consumption and we talk about problems, and they're highly intercorrelated, but it's very hard to predict at what level someone's going to have specific problem. It's not possible to predict that at what level with much certainty someone's going to have a specific problems. So generally speaking, the recommended level not to exceed in terms of alcohol by the NIAAA is no more than 2 drinks on average a day for men or 1 drink on average a day for women, which recognizes, but I think overstates the difference based on sex. And no more than 3 standard drinks in a day for women and 4 standard drinks in a day for men. So no binge drink. Those are higher than the literature suggests is really safe. So we did a study of the United Kingdom Biobank, UK Biobank, which is a wonderful data source that has drinking levels for people. It has genetic data. It has a lot of structural MRI data. So we took structural MRI data, magnetic resonance imaging data, and looked at different levels of alcohol consumption and showed that certainly above 1 drink a day, there was an associated lower level of gray matter volume, lower gray matter volume, white matter volume, and white matter integrity. And as you increase that, now this is a cross-sectional study, so we can't say that the drinking caused the observed differences in brain volume and integrity. But as you go higher, it gets worse. And it, in essence, is at some levels, it's like aging 10 years in terms of what your brain looks like. And so based on that, I think and my own behavior changed. I like wine. I drink wine, but I drink an average of 1 glass of wine a day or less, and I don't drink every day. Now I've also gotten older, and I drink less because I've gotten older. You'll see, but that's probably a good limit to think about when you are considering your brain health and other health. I mean, it affects all bodily systems. So alcohol is distributed in the aqueous phase of your body. What does that mean? Well, your body is comprised of water, mostly water, and non-water, so fat and protein, etc. So protein is actually considered part of the aqueous phase. So it's water soluble. Ethanol is water soluble. So anywhere there's water in your body, when you drink, ethanol goes there, and it's distributed that way. That's why body mass and body type influence blood alcohol levels because of the distribution. You metabolize alcohol about 1 drink an hour. So if you're drinking more than a drink an hour, your blood level is going up from the first drink. And it's metabolized largely in the liver. And it's called zero order kinetics, which means it doesn't matter how much you take in, it's still got the same rate. It doesn't increase to accommodate a greater ethanol load. And so as you're drinking, your blood alcohol level is going up depending on the rate at which you drink. That's just physics and chemistry.
So would you say that binge drinking once a month is worse than like drinking like 1 glass of wine a day?
It's hard to make that judgment. It certainly puts you at greater risk of acute consequences of drinking, accidents, doing something stupid. Those are increased when you're intoxicated. Drinking 1 drink a day is probably not going to cause that. Now, the health consequences are much more difficult to gauge because they accrue over a long period of time. So from my point of view, the safest drinking is 1 drink or less a day on average, and never do I drink more than 2 or 3. That's just the guide I use for myself. Other questions? Okay, so DSM-4 is now been supplanted, if you will, by DSM-5. But if you used it to collect a lot of data, like we did in the Yale pen sample, which you'll hear about ad nauseum, we're still using DSM-4 criteria for most diagnoses because it wasn't possible for us to translate many of the disorders from DSM-4 to DSM-5. The substance use disorders we could translate. So we have DSM-5 diagnosis for those as well in the Yale pen sample. Just to give you an idea of what that is, the Yale pen sample is a sample that we started collecting, Joel Galernter and I, he's at Yale, about 20 years ago, and we've accrued now about 17,000 people whom we've interviewed personally, but we've had people interview with about a 4-hour diagnostic interview called the SADA. And so we have information on about over 20 different categories of behaviors: substance use, alcohol, cocaine, opioids, depression, bipolar disorder, anxiety disorders, early childhood experiences. And so we use those data a lot for analysis because about 10,000 of the sample also have genome-wide genotype data. So in DSM-4, there was a distinction between abuse and dependence. So abuse was one of 4 criteria, like driving while intoxicated frequently. Dependence was 3 of 7 other criteria. So there were 11 criteria total, but they were differentiated into abuse or dependence. And if you got the dependence diagnosis, you didn't get the abuse diagnosis because that's the way it worked. It was hierarchical. So this was in place from 2000. I can't remember when it came into play, but it was supplanted by DSM-5 in 2013, 1994. I think DSM-4 came into place. So it was around for almost 20 years, and so a lot of studies are based on diagnoses made using DSM-4. DSM-5 took a more empirical approach. It also is a problematic pattern of substance use leading to clinically significant impairment or distress. And so what that means is you're using the substance in ways that are causing problems and causing you or others, but you as well, distress. So people generally are aware when they're drinking too much or using drugs too much. And so these criteria apply across substances. So I talked about alcohol, but these apply to opioid use, cannabis use, cocaine use, amphetamine use, etc. And DSM-5 takes those 11 diagnostic criteria, with a little twist, I'll tell you in a minute, and says if you have any 2 of these in a 1-year period, you meet criteria for a use disorder. So if you have them related to alcohol, you get alcohol use disorder. You have them related to opioids, you get opioid use disorder. And these are mild, moderate, or severe, depending on the number of criteria that you meet. The twist on going from DSM-4 to DSM-5 is even though it's all 11, even though there are 11 criteria when you combine abuse and dependence in DSM-4 and 11 criteria in DSM-5, they're not exactly the same criteria. There are a couple switches. Craving was added to DSM-5, and legal problems was removed in DSM-5 and present in DSM-4. So that was a little switcheroo. Questions about this? Now, this may just seem legalistic and not particularly informative. It's certainly legalistic, but it's useful to know about this. You're going to see this all over the place. You're going to see DSM-4, DSM-5. It's going to be anywhere that there's a clinical population. This is the yardstick that's used to evaluate whether they have a diagnosis, the severity of the diagnosis, and often the number of criteria are used as a covariate, for example, in statistical analysis. So this just shows you, is this your screen share? Oh, I don't need screen share, do I? Is anybody? Oh, yeah, I
Yes.
do, right, okay. All right, so this is a crosswalk, and you can see in DSM-4, you have 4 abuse criteria: hazardous use, problems, social or interpersonal problems, neglected major roles, legal problems. In DSM-4 dependence, none of those apply, but you have the more standard criteria: withdrawal, tolerance. So withdrawal is a manifestation of physical dependence, not the same as DSM-4 dependence. Physical dependence is one criterion for the dependence diagnosis. Gets a little complicated. Use larger amounts or for longer periods than planned, et cetera, et cetera. So you have these 7 criteria for dependence, and you need to meet 3 or more of these to get a dependence diagnosis, and 1 or more of these to get an abuse diagnosis. In DSM-5, you have no legal problems, but you have craving, and you need to have 2 or more criteria to get the DSM-5 diagnosis. And all of these are in the past year for current. And lifetime is any time, including current, but going further back at any point in one's life, any 1-year period in one's life. Questions?
Do you think that the DSM-5 should have like this distinction between abuse and dependence, or do you think they changed it because it's not necessary? I guess.
The latter. There are good data to show that criteria for abuse are present are more reflective of severity than some of the dependence criteria. So the notion was that abuse was not as severe as dependence, but the criteria don't match up to that. And so that was the basis on which the decision was made. The biggest knock on DSM-5, I think, is that having only 2 criteria to get a diagnosis means that more people get a diagnosis. Not dramatically more, by the way, because we've compared them, but more do. And some say that that's really undermining the notion of the dependence syndrome, which is a concept that was developed a long time ago, probably 40, 50 years ago, that has held sway in a lot of biological approaches to addiction. So the argument is that people who meet 2 criteria, have mild alcohol use disorder, for example, are different biologically than people who have 6 criteria. Because there's a syndrome that is present in someone who has 6 criteria that is not present in people with 2 criteria. This is an empirical question, and some people have sought to address it. And it's not something we could do, for example, in the Million Veteran Program. So the Million Veteran Program is another program you're going to hear a lot about because we use the data a lot. Much bigger sample, but it's not individually diagnosed using structured interview. based on electronic health records. And so we don't have the granular data from EHRs that we do from Yale Penn. We can answer this question in Yale Penn, for example. And that may be something that someone wants to try and do.
Could you elaborate a little bit on why it went from Roman nomenclature to numbers?
No idea. No idea. People had a hard time with Roman numerals, so, you know.
No, that's a good question. I was wondering that too.
Yeah, I've wondered it myself. I don't know. I can ask somebody who was on the committee, maybe they know. Debbie Hassan was on the committee, I think she. And the reason they added craving was because of Chuck O'Brien. Chuck O'Brien founded this center. He's retired now, but he was a strong advocate of craving as a criterion for a use disorder. And I think he just was so emphatic about it that the committee relented, but the data don't really support the use of craving as a criterion.
But what about, like, last week you were talking about, like, relief drinkers? Like, wouldn't craving, like, go into that, like, specific kind of drinking?
You know, I'm not sure that if you looked at, that's another empirical question we can answer in our sample. We only have a small sample that we're comparing relief and reward drinkers so far, but I don't know if anybody's looked at whether craving differs for reward and relief drinkers, because craving is not one of the criteria that goes into differentiating those two groups. And I don't think, well, we'd have to look at the IDS, the Inventory of Drinking Situations. It's a 100-item questionnaire. We use parts of that to make the distinction between reward and relief drinkers. I don't think craving is one of the questions we use.
Nope.
It's a good question. So you would think it might be more present in relief drinkers. Well, I would, and I'll tell you why I would. Relief drinkers are probably more advanced in their drinking careers, meaning early, at least there are theoretical formulations that say early on, people are drinking more for the reward, and it's only later on that the negative aspects of relief drinking emerge. So, you know, positive reinforcement is reward. Negative reinforcement is the relief of discomfort, if you will, or negative experience. So reward drinkers drink for the reward. Relief drinkers are negatively reinforced by drinking. And the thinking is that relationship between that reward type differs over the drinking career. And so I think craving occurs later on, more severely dependent people. So it might be more likely to occur in relief drinkers. I have never put a lot of stock in craving. That's just my own bias. Much more interested in what people are doing in terms of their, I'm much more concerned about somebody who's drinking over what I consider an appropriate level, whether or not they have craving. It doesn't matter. It's still toxic. So again, it's a matter of what you put in your gullet that really counts, at least for alcohol.
I mean, it can also go into, like, their, I don't, like, maybe not motivation, but, like, you know, why they're, like, I don't know, because somebody that is craving, like, one type of substance is definitely gonna, like, use more.
Not necessarily.
There.
No, the relationship between craving and use is not as clear as it should be, but semantically. And I mean, the classic study that I dismiss is one in a clinical trial of a medication, for example, in which you don't see changes in drinking, you see changes in craving that favor the medication. I don't think that's a positive study. I think that that's that's a negative study. I mean, I don't care if somebody's craving, clinically, if I see a patient, I don't care that they're craving less. Unless that craving has implications for what they're drinking. Or which their substance use. I often lapse into talking about alcohol, because it's what I tend to study most, but it's similar, these apply to other substances. And craving varies. Craving for alcohol is not as easy to elicit as craving for cocaine, for example, using visual images, for example. A lot of cue exposure uses visual images as cues, and it's much easier to elicit a craving response, a subjective report with cocaine than it is with alcohol. And tobacco is another disorder, and opioids another disorder where the disorder is characterized by high levels of craving. Alcohol less so. Okay, so ICD-9 this is from ICD-9, this quote, and it suggests that it's a little more freewheeling than DSM-4, for example. These Europeans, they're pretty freewheeling, it's like, so it was intended to provide clinicians with a certain amount of freedom in decision making. And there was no strict conditional clauses for symptomatology, duration, or severity of the disorder. There are criteria, but they're sort of a guide. ICD-10 changed that, and it became much more like DSM-4. And you can see that in these criteria, which much more closely resemble DSM-4. So why do we use ICD diagnoses in the electronic health record? Anybody know? Pardon?
Billing.
Billing, exactly. Well, billing and other statistics, but principally billing. Yeah. So to strictly answer my question, we use them because they're there. That's what's in the EHR. And the reason is what Zeal said. That's why they're in the EHR, because hospitals and other clinical entities bill based on ICD codes. And ICD-10 was an effort to bring ICD-9 into greater harmony with the DSM. Now, the other difference between DSM and ICD, and the reason DSM could never be used widely in EHRs, is because DSM only concerns mental disorders. ICD is all of them. So there's a code for all kinds of things. And it's an international nomenclature.
I think there's an ICD-10 code for losing your left leg while on a powerboat or something ridiculous. Yes. I'm not even joking. I think there is.
Yeah, there are.
They get very specific.
Yeah. So this is the ICD-10 substance dependence criteria. So there are 3 of 6. A strong desire, a sense of compulsion to use, craving. Impaired control over use, tolerance, withdrawal, progressive neglect of alternative activities, and continued use despite harm. Those are all in the DSM-4 dependence diagnosis and DSM-5 use disorder diagnosis. Those are key elements of disorders related to substance use. So impaired control over use was immortalized by Mark Twain when he said, "It's easy to quit smoking. I've done it 1,000 times." And tolerance is using more than you used to get the desired effect, 50% more. or experiencing 50% less of an effect at the same dose. So if it used to take 3 drinks for someone to feel good, and it now takes 6 drinks, that's tolerance. Withdrawal is a constellation of signs and symptoms that vary by substance. Tremor, for example, is commonly seen across in a number of disorders. Craving can be, but feeling sick, blood pressure changes, autonomic changes. This is a manifestation of physiological adaptation to the effects of a drug. And the withdrawal symptomatology is usually opposite in direction to the acute effects. So acutely, alcohol is a brain depressant. When you withdraw it from someone who is physically dependent, they manifest excitation and frequently are tremulous, are unable to sit still, are anxious, are sweating. And similarly, opioids are pain reducing and calming, but during withdrawal, people are agitated, they're feeling sick, they're experiencing a lot of pain in their bones, they often describe it. Progressive neglect of alternative activities is a little harder to nail down. A clear example is parenting. So if substance use gets in the way of parenting, that meets the criterion. If it gets in the way of doing your job or other required activities to maintain one's life, then it meets the criterion. And continued use despite harm is, I know that the stomach pain that I feel when I drink a lot is related to drinking, but I do it anyway, and then I just tolerate the pain, or I take antacids or whatever. And this can be psychological harm too. It can be depression. People know that their depression's worsened when they drink a lot, but initially it's relieved, so they drink, and they feel better transiently, and then they feel depressed.
I have a question. So I was talking to Emily about this yesterday about marijuana and how it's like, how you can categorize it as a substance dependence. It's like a little different than like other drugs. So I was thinking, because I know people that have taken like tolerance breaks, and that like is one of the criteria for this diagnosis. So I
Right.
wonder.
So you're talking about people who smoke pot and they take a break so that they can reduce their tolerance.
Yes.
Yes.
So like how like I was asking.
That ain't a good sign.
Right.
That's what I
Yeah.
said.
Right. But then it's like I don't really hear people talking about marijuana in the same way that they do about other drugs. For
You will around here.
But like in the way that they're like, I don't know, like most of these like criteria, I don't think will apply to like the way that most people.
Yeah, well, no, you're right. I mean, the pattern of criteria that are met differs across substances. Most commonly differs across substances. But impaired control over use. I wasn't going to smoke tonight, but I decided I'd smoke a little, and boom, you're slammed. Tolerance, there's some evidence of withdrawal from high levels of use. Progressive neglect of alternative activities. School's a great example, right? And continued use despite harm can be. So yeah, you can meet the criteria with cannabis. I grew up at a time when cannabis was not considered at all acceptable. It was illegal everywhere. And I don't think it's a good thing that we legalize cannabis, because I think people now just have one more tool to destroy themselves or harm themselves. Now, I'm not crusading. Let me be clear. I'm not going to judge anybody based on their substance use. But from a societal level, I think we're now seeing a lot more cannabis dependence or cannabis use disorder than we would have had we not legalized in so many places.
So should we not have legalized alcohol either?
Oh, well, there is that argument to be made. During Prohibition, first of all, alcohol has a much longer history with humans, but and it's so and I think it's much more intertwined with life. So the idea of prohibition was just wasn't going to work. It didn't work. But during Prohibition, if you look at what happened to deaths from cirrhosis of the liver, it went like this during Prohibition, and then once Prohibition was lifted, it went back up. So I mean, there are clear health benefits to not drinking. Yes.
I was gonna say, like, isn't like with alcohol or even like legalization of marijuana, isn't that more of an issue of regulation rather than legalization? Like, you know, the way we also regulate alcohol, like it is so widely available that like there are even like people who get like fake IDs and they can buy alcohol.
No. Really? Well, no, so they're part and parcel of the same thing. So laws are the basis on which regulation occurs. So if there are no laws, there's no regulation. If there are laws, there can be different levels, different kinds of implementation or regulation. So I think they're part and parcel of the same thing. If you look at Scandinavian countries, for example, policy is to tax alcohol beverages really highly. And so they're very costly and it reduces consumption. Now, those of you who live in Pennsylvania know that you can't, until recently, you couldn't buy wine in a store. You can now buy a limited number of bottles, but basically it's still a monopoly. The PLC, the Pennsylvania Liquor Control Board, stores fine wine and good spirits. That stemmed from Prohibition and is a way at the societal level to limit alcohol consumption. Blue laws that don't allow the purchase of alcohol on Sundays or on Sunday mornings so that people could go to church and not be intoxicated are another manifestation of that. So, I mean, you're right. Control is inherently a part of these. And cannabis is, the effort now is to control it. The effort is, I think the thinking, and I'm not sure it's right or wrong, jury's out. If you legalize it, you have better opportunities to tax it and control it. And taxing it is not a trivial aspect of this as a way of fundraising. Anyway, yeah.
5 minutes.
Yes, ma'am. There it is.
Beautiful. I
good.
have a question. So we briefly discussed this yesterday when I met with you guys, but we were discussing the difference between OUD stringent and less stringent and how we use ICD codes to define that. So can you explain a little bit more on that?
Yes, that is a post hoc approach that is used in a lot of electronic health records research to increase the specificity of the diagnosis. So sensitivity is the capacity to detect something that's there, and specificity is the capacity to correctly determine it's not there. So the stringent approach is to require 2 outpatient diagnoses or 1 inpatient diagnosis. The thought being that if you have 2 outpatient diagnoses, which are probably less valid than an inpatient diagnosis, the outpatient less valid than the inpatient, so you need 2 of them, then you're more likely to actually have the disorder. The less stringent is a more sensitive approach, where if you have any diagnosis, inpatient or outpatient, just 1, you're going to capture more people. And we've tested, Rachel in her opioid use disorder, GWAS, looked at that and found that the less stringent was more informative in terms of identifying genetic variants related to opioid use disorder. Now, whether those are true positives or false positives, one could argue, requires empirical validation independently.
We did also look at the number of opioid prescriptions for people with just a single ICD code, and they had as many as someone with multiple ICD codes for opioid use disorder, which isn't a
It's a concurrent
so it's-
validator.
It
Right.
suggests that the people even just with one code probably had opioid use disorder.
Yeah, a really interesting question whenever you get into diagnosis is epistemology. How do you know what you know, and how do you prove what you know? So there are different ways of validating. I did a postdoc with a social psychologist who was very much into the notion of validation. And Kronbeck was one of his heroes. You'll read about Kronbeck's alpha, which is a way of looking at internal validity. But the whole notion of validity, I mean, it really has strong philosophical roots. And how do we know, Kantian philosophy, Immanuel Kant, how do we know what we know? How do we, these are really interesting questions. And diagnosis is really a part of that whole broader philosophical question. I don't remember what this.
Evaluations, if you are a student.
Right,
Not
that's what-
staff, only the students, if you can fill this out, I will also email you the link later. And I don't pretend to be a student. No.
You don't get to rate us.
Just a quick survey, this helps out the youngins on the faculty quite a bit, but it just gives us some data about what you liked, what's helpful, what you learned.
And the reason it helps them is because one of the criteria that Penn uses for evaluating reappointment and promotion is ratings by students. So we're not asking to be anything but honest, but that's the rationale.